Transference is something which is extremely important in psychoanalysis. In fact, the whole psychoanalytic discipline gets divided into two in terms of approach. One which is called psychoanalysis, a pure psychoanalysis. Second, which is called psychodynamic psychoanalysis or psychodynamic approach. The difference is in quintessential psychoanalysis, you heavily work in transference. But in psychodynamic approach, the intensity of using transference is less. So that is what distinguishes a pure psychoanalytic approach from a psychodynamic approach. And most people actually go for psychodynamic approach, except for a few Puritan psychoanalysts. Within that, more so Kleinians, because Kleinians heavily use transference. In fact, transference starts the moment the patient picks up the phone. That's what one of my supervisors used to say, and often it is true, because the patient feels unconsciously that he can't fix himself and somebody else he has to go to, and then the omnipotence projection starts. And with that, the projections, the transferences from the parents and other significant figures, that also starts. So the transference is always there. In fact, it is there even in everyday life. It is not that it happens only in the therapy room. Transference is everywhere. It's a very ordinary psychological process, but happens very intensely in the therapy room. So let us go into what transference is. Last time we saw welcome, Madhusudan.
Hello, sir. Good afternoon.
Good afternoon. Last time we talked about movement of affect in the psyche, and we said affect can move from one object to another, and it can move with regard to the same object in the direction of increasing intensity, which we call cathexis, meaning affect is generated more and deposited on an object, which is what we call toning up the object with affect or cathexis, or release of affect. So we see one movement of affect is from one object to another. And the second movement of affect is where affect gets loaded or released from an object. So when we look at movement of affect from one object to another, we say it's displacement. And when displacement gets in the element of a role, a social role, we call it a transference. So transference is a unique kind of displacement. We saw last time that only displacement happens in cases of phobia, in cases of fetish. Whereas in the therapy room, when the person transfers feelings from the parents or significant others to the therapist, that particular kind of role involving displacement, we give the name transference. So it's a displacement involving a social role. Now, when we talk about movement of affect, is transference limited to affect, or can you be attributed with non-affective elements also? The patient may say, you think exactly like my father. Or he may start imagining that you are thinking exactly like his father. So you can have a transference of thought, transference of affect, transference of orientation, attitude, templates, character, and most importantly, transference of omnipotence. This is very, very important the transference of omnipotence. The Kleinian would call it having the split open and transference of the omnipotent good object onto the therapist. The Freudians will call it transference of the omnipotent father onto the therapist. Winnicott will call it transference of the good enough sought mother onto the therapist. It can also be a dreamt of object which actually you never had. So one of the Lacanians, Zizek, he makes a comment. He has written a book, The Sublime Object of Ideology. That through any ideology, we are essentially pursuing that omnipotent good state, whereafter there will be no difficulty. It will be like heaven come true on earth. That implicitly is the intention or the motivation behind every ideology. Search for that all good state. In Kleinian terms, we will call it search for an all good object. I have rephrased it in one of my talks. I call it the dream we never had. That we dream today as though we once upon a time had this and now we don't have it, but once upon a time we had it and now we want it back. But often it is a retrospective recreation. At times it can go back to the state of primary narcissism where there was oceanic experience and bliss. And at times it can just be a recreation of something we never had. So that is the game of omnipotence, which is very important in personality disorders. Because in all psychoses and personality disorders, the game of omnipotence will be very much on. So it can be transference of omnipotence. Transference, as we said, starts the moment the patient picks up the phone to call you. Or even before that, the moment somebody mentions that you are a good therapist. And he starts thinking about whether to go to you or not, the transference starts. Transference is always there, even in ordinary situations, not necessarily only in the therapy room. Because unfulfilled desires, unresolved complexes will never keep quiet. They are like troublesome, mischievous children in the psychic classroom. And we will always speak with our entire past, unknown to us and unknown to the other. The one who has the capability to read will read to the extent his capability allows. But we always speak with our entire past, unknown to us and unknown to the other.
Is it the same as Kobold in Keller?
Can you elaborate?
Yeah, the whatever Freud said that it is the hobgoblin in the attic or kobold in Keller or in the basement.
Correct.
Where you cannot enter alone. You have to have the analyst's hand. Otherwise, right, you might get traumatized.
True. True. That is true. That is true. And one of the difficulties with transference is that it needs an object to activate itself. It cannot activate without an object, and unless it is activated, you can't identify and heal. So Freud actually had completely different ideas about transference in his lifetime. Initially, he thought this was a difficulty, a problem, a resistance. So he used to use the word transference resistance. that transference actually is a resistance to cure. Later on, he came to realize that this is actually a communication. This is actually activation of what wants to be healed. And it's a very positive thing. In fact, if it does not happen, that is trouble. So initially he used to call it transference resistance, and later he used the phrase resistance to transference. So from transference resistance to transference was Freud's own journey to find out how valuable transference is. Freud also had a very strange idea, a belief that narcissistic people and psychotics, they don't make transferences. On narcissistic people, he still was a little loose, but on psychotics, he was very clear that probably they don't make transferences. The idea was they don't repress anything. They have created a world out of their repressed desires. So when there's nothing to repress, why should anything move from one to the other when nothing is repressed? Because the unconscious is living itself out in reality. The man is dreaming with eyes open. But now we know, and later on, even as early as Klein and Jung came to realize that psychotics also make transferences. In fact, they make very strong transferences. And narcissistic people also make transferences of a very different type. And I'm referring to a pure narcissist. So everyone makes transferences. Yeah.
Sir, so does that mean that transference is not related to resistance? Sorry, to repression.
It is definitely related to repression in some way or the other. What we find is that in psychosis, the situation is not of no repression. It is that the repressive layer has been punctured at a few points. Because even in the worst cases of schizophrenia, we definitely find repression. Like,
Okay.
it is never the case that the whole lid of the unconscious has opened and the whole thing is now out in the open. So what we have is holes in the repressive barrier, not the absence of repressive barrier. And that is one of the reasons why even in the schizophrenics, even in those who act out their desires, you still have repression. Just that they don't have the ego strength to do such strong repression that could repress the strong material inside. In fact,
So,
those who are on the ego, sorry, please go on.
sorry, so Lacan has a famous line that the unconscious is open to the sky. So that is not true.
No.
Right. Okay, fine. Yeah.
We don't find that even in schizophrenics, the repression is not there. In fact, even in schizophrenics, we have to work very hard to undo the repression and get the effect out. Although part of the effect has broken through the repressive barrier, created the projection. Let us say, for example, somebody has violent desires for his father, and part of it has been projected out, and he's suffering from delusion of persecution. He's paranoid that somebody is going to attack him. But even in his case, when we explore anger towards the father, we have to really do hard work, session after session after session, to undo the repression and also undo the resistance.
Okay, sir. Thank you. Yeah.
So transference definitely is related to repression, in different ways. It brings us to a very important question of a extreme kind. That can you have Mr. Id who does not have ego or superego? Both have been put aside and the whole id is out there in the open. That kind of individual we don't find usually. And even if somebody was to get into that state, very soon he would be in the asylum or in a prison. It's very, nobody has documented a situation where one just sees a complete absence of ego and superego. There may be a failure of operation of ego and superego, but to have a complete absence is very difficult, even in cases of psychopaths. That you may have at worst absence of superego, but never an absence of ego, even in psychopaths. And the moment you have ego or superego, because both of them are partly in the conscious, partly in the unconscious, the defenses would operate and repression would happen in some way or the other. Now, a very important part is in psychosis, there is a very interesting thing. In psychosis, when the patient starts believing in many cases that you are crazy, that is a very good moment. Because often you see that after that, the healing starts much better. After the patient starts believing that you are crazy. Now, one of the ways to explain this is that perhaps he finds you safe enough and strong enough to contain those projections. So what was put out now is put on you. At least it has come from outside the therapy room into the therapy room. And now if you can contain and you can analyze and not get carried away, and he can see that you can contain, and that brings in the whole idea of containing the projective identification. And often before that, he will test you out. So it's a very important thing that often before the healing process accelerates, they feel you are crazy. Now, a very important point, different schools and transparencies. Like we said, something is moving from one object to another, usually from the past to the present in the therapy room. Now, what is moving from one object to the other, from the past to the present? That depends largely to the school that you are looking at. So different schools will look at transparencies differently. There is an old saying in psychotherapy, what you don't know, you can't see. Which means everything is happening, but based on our training, we are able to see only a few things. So let us see how it works. Let us say if you are practicing as a Freudian and you know the Freudian concepts, you will look at parental transference, you will look at Oedipal transference, you will look at sibling rivalry transferences, you will look at bisexual, homosexual transferences. But you will be limited by this. You are not going to look at a big other transference. Only if you know the concept of the big other, you will be able to find big other transference. That does not mean it does not happen. So if somebody is not trained in Lacan, he can still encounter in the patient a big other transference which he can't make out what it is. So everything happens, but we are able to identify only those things that we are knowledgeable about. So if you are trained as a Freudian, these are the transparencies you will recognize and you will work with. If you are trained as a Kleinian, you will be looking at good and bad object transparencies. That I was looked upon as a good object, suddenly I have become the bad object. I was looked at somebody benign and suddenly I have become evil. I was looked at somebody very capable and suddenly he says you are good for nothing. At times he found it very fortunate he was with you and suddenly he says I doubt why I am here. Then you have the transference of omnipotence. Then we can have transferences of envy and greed because these are very important concepts in Klein. Good and bad object, envy, greed. These are very important concepts in Klein. So if you see the nature of transferences and nature of interpretations in the Freudian scheme of things, it will be more erotically loaded, more sexually loaded. And in the Kleinian scheme of things, it's more aggression oriented. So the Freudian approach is very libidinal approach. Kleinian approach is very aggressive approach, centered around aggression. Freud is centered around sexuality, erotica. Now, if somebody is a Jungian, he will look at archetypal transference, meaning the archetypal figures like the poet, the warrior, the saint, the teacher, the healer, the preacher, the age-old social roles in human civilization. For Jung, these are very important archetypes. When we do Jung's model of the mind, we'll go in details of how archetypes are situated in the mind and how they operate. But Jungians will talk about archetypal transferences, which no Freudian will talk about. That does not mean it does not happen. It's just that we don't know and we don't recognize and we don't use. Kohut, you have very interesting transparencies because Kohut has done a lot of work on narcissism. And Kohut talks about self-object transparencies. So many people say narcissistic people don't make transparencies. It is not true. They make transparencies. But in an extreme situation of somebody being completely saturated with oneself, you will still have self-object transparencies. Meaning, they want somebody who is an extension of them. They don't see you as a separate person, but as an extension of them. Typically, what a narcissist wants a dependent to take up the role in his relationship. So the narcissist is always looking forward to a dependent who is there just to obey him and serve him and be an extension of him. So he is not looking at a second person. He is looking at a half person. That technically there is another person, but he acts like an extension of me. So that Kohut calls a self-object, self-object. It's always written like this, self-object, meaning there is an object, but the object is not an autonomous, independent object. I see that object as an extension of myself, So myself finds an extension, and that is called self-object. That the other person does not have autonomy and desire of his own. He lives my desire. He lives my commands. He feels he is useful only if he is useful to me. He does not see any meaning in his own existence apart from the omnipotent person to whom he is attached. So what the narcissist will do will be, he will want the therapist also to behave like a self-object and not make interpretations which attack his narcissism. And this is where Kohut is different from classical psychoanalysis. The classical psychoanalysis will say the moment somebody tries to live out his narcissism, you interpret it and be an agent of reality. Because this is the pathology you cannot allow to pass. You have to make an interpretation. By not making an interpretation, you will be siding with the pathology. You will be giving a message it is okay to be narcissistic. That these narcissistic beliefs that you have are real and true. This is the classical way of approaching. And the person who has done a lot of work there is Kernberg. And on narcissism, these are the two experts, Kernberg and Kohut. So Kernberg essentially is rooted in Klein and classical psychoanalysis, which would mean Freud, Klein, Bion. These are classical psychoanalysts. Jung is very different, what we call analytical psychology. Very different from classical. And Kohut is radically different because Kohut's approach we call self-psychology approach. And what Kohut says is this. He says, allow the person to live out his narcissism. Don't interpret. When you interpret, he will repress it and it will go deeper in. But if you allow him to live out, then after some time, he will automatically take the path of reality. You just have to be patient that he is able to live out his narcissism in the therapy room, and his journey towards reality will start after he has lived it out enough. So Kohut thinks of narcissism as an arrest in development. That because of something traumatic, the developmental path has seen arrest. And by allowing him to live it out, you are undoing that arrest. So cohesion therapy usually is very long. Interpretations are held back for a very long time. And it's more holding. So in cohesion therapy, if we know those concepts, we can see self-object transparencies. That the patient does not want you to do any interpretation. He just wants you to be a more knowledgeable extension of himself. And according to Kohut, unless adequate amount of self-object experiences are had, the person will not be able to overcome his narcissism, which is radically different from the approach of classical psychoanalysis. So there we see self-object transparencies. Similarly, Kohut talks about mirroring, which is very different from Lacan's idea of mirroring. And at the same time, there is a confluence area also. For Kohut, mirroring means 5 A's. The first is acknowledgement. Second is attention. Third is acceptance. Fourth is affection. And the fifth is admiration. The 5 A's. And according to him, if those who are around us in early childhood, they don't provide us these 5 A's adequately, it leads to the formation of an unhealthy self. And in dependence, you can see the crisis is of attention by and large. The crisis is of acceptance. The crisis is of affection. It's a mirroring crisis. So you can see mirroring transparencies. The person is seeking acknowledgement. The person is seeking attention. Or idealizing transference. Kohut talks about internalizing an idealized figure in early child. So Kohut talks about the self-object transference, mirroring transference, idealizing transference, meaning the patient will like the therapist to be a self-object, an extension of himself, allowing him to live out his narcissism. The patient would like to project the 5 A's: acknowledgement, attention, acceptance, affection, admiration onto the therapist, or the need for it, or project idealization. So now you can see, based upon which school you know, you can identify transferences. The normal transferences everyone can identify is that of parents, that of siblings, that of teacher, that of somebody very powerful, that of omnipotence. But rest of the transferences are very theory dependent. When you know the theory, you can recognize those transferences. Any questions here?
Sir, mirroring transference is not very clear to me. Is it the same as psychotic transference,
No,
wherein the patient believes that he is the therapist?
no. This is a very neurotic thing. Somebody who has deprivation of the 5 A's is transferring the need for somebody who will mirror well onto the therapist. How does the mirroring work? In, let's take in 2 ways: in the transference process and in the projective identification process. In transference process, let us say you start giving far more attention to a patient than usually you do to others, or you start showing far more admiration to one patient. That may be your counter transference in response to his transference of a affection giving parent onto you. That you start acting it out in response to his search for it. So through the transference counter transference process, he is fulfilling his deprivation. And in projective identification, they will make you realize that this is my problem. For example, usually I don't forget sessions, but for one person I forgot a session. And it happened twice. And that is where I realized that what he was transferring onto me was that everyone forgets me. My problem starts from acknowledgement of my existence. That nobody acknowledges my existence. Nobody gives attention or importance to it. Everyone dismisses me, and that is my problem. So they will make you forget the session, the appointment, or something. That is how, through projective identification, they will communicate a mirroring deprivation. Or if you are not idealistic enough in their eyes, they will communicate it to you that a therapist ought to be like this in different ways, because they are in need of making an idealizing transference, and you are not presenting themselves as ideal enough. Or you are making interpretation upon interpretation, and they want you to do holding and be a self-object. They want to say, for God's sake, don't give me your wisdom, just listen to me. Everyone has been giving me wisdom all the time and I'm tired of it. I know the solution to my problems, just keep quiet, be with me, and allow me to accept my solutions. Just keep quiet and be with me as a amoral, acritical, empathic, listening person. That's what I want. I don't want your solutions. I know the solutions. It is just that I am not able to accept my solutions because nobody has provided me that safety and that attention and that support where my rage does not come up and does not allow me to accept my own solutions. So what happens is, this is what happens in very good containment, that you are just keeping quiet. The person speaks everything, you don't say anything. After the session, he automatically goes and solves the problem. He already has a solution. He is just waiting for a empathic, compassionate person to just listen him out without giving advice, without criticism. And once he finds it, he will implement the solution. The defiance and self-destruction will end. It is like a boy wants to give up cigarette, but the father keeps saying give up the cigarette and therefore does not give up the cigarette. The day the father says, fine enough, your choice, do what you wish, I have no problem, enjoy yourself. After 6 months, he will give up the cigarette himself. Obviously, no rule is universal. This will apply to a group and not apply to a group. Yes, please.
Sorry for joining late, first of all. Um, Sir, when we talk about this neurotic transference, till how far this transference remains to the space of healing? Because technically, transference, when a person is seeking that kind of a projective container or things out there, but then there comes a time in the therapy where a therapist has to take a call and do something about this. What is that element which makes a therapist pick up that call and say that, okay, now enough of it, now we are actually either diverging from the main thing, because there is a knowing inside where we know that, okay, now it's enough is done, now we need to move on. So what are the parameters there that we decide?
It's a very good question, because the question can be rephrased to say, when do we bring in the Kohutian method and when do we bring in the classical psychoanalytic method? When do we sit in the chair of interpretation and when do we sit in the chair of holding? The first element that gives us a direction is the case history. That does the person look like having a mirroring deprivation? Second is our interpretation. Usually we start with the classical method of interpretation and we see the outcome. If the outcome is not there, then we switch to the Kohutian method. That is second. That interpretation does not give us result. So we switch to the second method and often that gives us a result. Third, the fragility. That are we looking at a person who is extremely fragile? If yes, then it is better to hold than to interpret. Because he may not have the ego strength to take the interpretation. It's too early. Fourth, has he had good containers in his life or not? If not, then we have to become the good container to start with, and then we can bring in interpretation later. Fifth, are we looking at a self-object transference? Like, is he not allowing you to be yourself? And is he forcing you to be somebody he wants you to be?
Sometimes this is the point where we have to cut that transference. I felt that many a times with many clients.
Yeah, so both things happen. If the person is healthy enough, you can cut it. If the person is fragile, then we have to allow it to be till the person becomes okay with it. Like holding till ready for interpretation.
What if we sense that it is the resistance to healing and holding on to victimhood, which is creating this transference.
Then we interpret. One more criteria. What is the character structure? Because the episodic illness may be something and the underlying character structure may be something else. Like you may have a neurotic character structure and a psychotic episodic difficulty, or a psychotic character structure but a neurotic difficulty of depression. That you see that the underlying personality doesn't seem psychotic, it seems neurotic. Although the episodic sickness with which he has come may be either of it. So if the underlying personality does not seem psychotic, you can go into interpretation. If the underlying personality seems psychotic, even if he comes with a neurotic difficulty of depression or addiction or something of that sort, you still will be in doubt what to do. And it's better to have that doubt and not conclude too soon. In a session or two, you will get a fair idea of whether you are dealing with a fundamentally neurotic personality or a psychotic personality, regardless of the episodic sickness with which he comes. So there the rule is, in the psychotic character structure, better start with holding. And in a neurotic character structure, one can start with interpretation even if he has psychosis. But if you see his ego strength is good enough in some way, I mean, obviously it's impaired, that's why he has psychosis. But if he has enough of it to take interpretation, one can even start with it. But as a rule, I would say in psychosis, in somatization, as a rule, better start with cohesion method of holding. Yes, please.
Sometimes in history, we have seen similar containers, of course, not from the therapeutic understanding when the parents are providing them. The indifferent parents, they just listen to the children and they don't do anything. Later on, when they come to the therapeutic setup and then this transference is taking place, that is the time sometimes they eject out of therapy thinking that this is the same pattern my parents, they listen to everything, they do not suggest, they do nothing about it, and
Correct.
that is the time when the patients eject. So
This is where the psychoanalytic method fails.
Okay.
Because you are dealing with a group who wants a prescription and you want self-discovery. And your silence is treated as dismissal of the parent. So the way to undo it is, if we have this kind of a case, then engage in a conversation and tell the person that I am not, my guidelines tell me that I cannot give a prescription because you have to live your life and I have no right to guide your life. Only you have a right to decide for yourself. But we can discuss everything that you want. So I am not abdicating. I am only empowering. So the more verbal interventions you make and indirectly communicate this, then you may save some of the patients from ejecting out, but some of them definitely will. Because they want prescriptions so badly that this method looks alien to them.
That's where the toolkit comes in handy.
Correct.
Where we use the other schools
Correct.
or some tools to provide them with something to pacify the need. Nice.
Because I remember what some patients told me of the same group. कि आप बात करने का पैसा लोगे? Then they will say, अच्छा तो बात भी आप नहीं करोगे, वो भी मुझे ही करना है, तो मुझे बात भी करनी है और पैसे भी देने हैं, तो आप क्या करोगे? Now this is a very different kind of group who need directed therapy, who need prescribing therapy. They are looking forward literally for a parent, mentor. They are not looking forward to somebody who will help in self-discovery.
What if it is a dependent personality?
He will not leave. He will not leave.
Right.
He will ask for prescription. You will not give it to him. He will insist upon it, but he will not leave.
Makes sense. Fair enough.
So from transference to counter-transference. So transference solicits our response unconsciously, and that is called counter-transference. Now, counter-transference usually is felt. Transference usually is deduced, not always. At times, person will openly speak about it. You remind me of my father. It's verbally explicit that I am having a transference. Or he will say, I feel guilty about speaking this to you. Or he will hold back something, miss some element in his narration, and we know very clearly that the superego is coming. The transference is going on of the parental figure. But otherwise, what we feel directly in ourselves is counter-transference, and from that we deduce transference, the subtle form of transference. Now, counter-transferences can be parental, that you feel like a parent to the person. So when you start feeling like a parent to the person, you know the parental transferences are on. When you feel seduced, you know Oedipal transferences are on. When you feel anger and irritation, either he is transferring something you are not comfortable with, or he is provoking in you the feelings that he has experienced from the significant others. Templates are awakened, that certain ways of behavior which are not usually yours awaken with a person, that with this person you behave in X way, but not left to yourself. That is not your 24-hour every day. Which means you are responding to some transference which is on. You feel you are treated like an object rather than a human being. He is communicating to you that.
Is it he that projecting what he feels onto you, or what he feels towards his authoritative or whatsoever personalities have in? Which, how to decipher that?
So the same thing can be communicated through transference, counter-transference route or projective identification route. If you start feeling like an object, it is projective identification. He is making you feel what he is feeling, direct. That this is how I have been treated all my life, like a piece of furniture, like an object, dehumanized. If you start treating him as an object, you start feeling towards him not like a human being, but like an object who has to obey you. Somebody you can control completely, somebody who can command and make do things. Then that is your counter-transference in response to his transference. Helplessness. Like he just does not say anything. He will give you a dream but refuse to give associations. He will make you feel helpless. Whatever you say, he will say, no, this is not true for me. Keep denying the problem. No, I don't have any problem. Then why are you here? I don't know. Now, that will bring you some sort of helplessness. What do you do? You can't use any of the tools that you know. So all these are counter transferences. Out of session counter transference also can happen. Meaning, after the session is over, you can start feeling the counter transference. It's a delayed counter transference. And the therapy ends, but the transference and the counter transference does not end. One of my teachers, his analyst passed away long back. But even today, he goes to his Facebook page, which is still there, it's not deleted, to see that Facebook page. So even after the therapy ends, the transferences continue. Similarly, counter transferences also can continue. Suddenly, somebody that you had as a patient long back, you start thinking about that patient in various ways. And often it can be seductive. So even after the therapy is over, transferences and counter transferences still continue. Yeah, Bhavna, you're asking something.
Sir, I remember one of the cases with an underlying psychotic personality traits. And I think there was this, the patient was on verge of entering psychosis. It was the first session, and prior his session, I had that transference, and I have was so confused at what is happening to my whole system. And eventually, when the patient appeared, and I knew, oh, it was him, because
Correct.
in somewhere the day he called up, from there onwards till that day, there was this kind of feeling was coming knowingly, unknowingly to me. So sometimes it is even prior the session starts when the
Correct.
person has already picked up the therapist.
So just before you joined, we talked about it. The moment the person picks up the phone, the transference starts. The moment somebody tells him he's a very good therapist and the thought occurs to him, should I go to him? The processes start. And it can go on for years and years, the transferences, even after the therapy ends.
So what is the main core element which put up the transference? Is it the id or the ego?
It is the id.
It's the id.
It is our unfulfilled desires and our attachments, our deprivations.
So in the therapy space, the transference is taken care by the ego, that is the interpretation.
Right.
Do they always have to be deprivations, or they can be fixations also?
Fixations also, both. And that is where the idea of Lacan's lack can be looked at in two ways. You can see the lack as a crater in the land, that there is a depression to be filled. Or you can look at it in another way. If the land is flat, but there is a desire for a mountain. That there is no lack in the sense of a crater, but there is a desire in the sense of fulfillment. Counter-transference and projective identification are difficult to differentiate for most people. It takes quite some self-observation and some practice to differentiate counter-transference and projective identification. Projective identification is easy to identify by verifying with the patient. Like suddenly when you start feeling angry, you ask the patient, are you feeling angry? And when he says yes, you know it's projective identification. And when you practice it 3-4 times, it gives you confidence that this is not my material, this is sent by him. A psychological courier has come. So always practice it out and you will see the truth of this esoteric thing. It's esoteric. It's not scientifically easy to explain how it happens. But the veracity of it is not in doubt. So counter-transference and projective identification, the core difference being both of them can happen in the therapy session, both can have a delayed forms. The difference being that in projective identification, you feel the same as the patient. In counter-transference, you are responding to the patient what the patient puts in. So patient puts A and you respond with B, which is counter-transference. In projective identification, the patient feels A, you feel A. And often they will make you get angry. And if you are not trained enough, you will actually get angry. Like, you may not quarrel with him, but the tone will change, the facial expression will change, the choice of words will change, and he will know in a subtle way that he has got you angry. And these are the tests before he puts huge amount of anger in you. Many people will make it open and say, in ISTDP kind of technique, that I am afraid what will happen to you if I express all my anger.
Mhm. That is projective identification.
He is afraid of projective identification. He wants to do it. He wants you to help him process it. And that he wants not by feeling himself and facing in catharsis. He wants to hire your system to do it. He does not want to do the difficult process, hard work himself. So he wants to go to the gym, but there he wants to sit on the sofa. So he has come to the therapy, which is a psychological gymnasium. He does not want to do heavy weightlifting here. So he wants to put it in you and for you to process. And when you interpret it, he owns it up.
Very rightly said by you, sir. It's like, you're offering your psyche to process for them, and that also reminds us as therapists that how sorted our psyche needs to be to allow that to happen.
Right. Because there's a very important point which I forgot. Because no human being is completely sorted out. There are two transparencies and two counter transparencies in the room. That because of our own not being sorted out completely, we will also make a transference on the patient, and the patient will have a counter transference in relation to that. And similarly, if we are even less sorted out, we will make projective identification also on the patient. And if you do that, the patient will run away. Because he will start feeling uneasy. Because you have put in a negative emotion, whether it's anger or envy or whatever, he does not know what is happening. He just feels uneasy. And he will just say, कि वहां जाता हूं अजीब सा लगता है, जाना ही नहीं वहां.
And in that case, sometimes if unfortunately the therapist or the psychiatrist, owing up to their humanliness, they have that narcissistic trait, and there's a dependent personality, that becomes a very long-term therapy.
Correct. And if because of dependence one is not able to resist the projective identification, because the dependent is more terrified of the loss than of the projective identification. So between bad and worse, he chooses bad. And he allows the other to make projective identification. And God forbid, and this is what has led people to even suicidal ideation. Yes, please.
Sir, I don't understand the last thing that you said.
I was saying that no human being is completely sorted out.
Yeah, that I got. But that point that you were making about projective identification,
Right.
bad and worse, yeah.
Okay. Let us say you have a dependent personality disorder patient. You are making a projective identification of anger into him. Now he has a choice to tell you, okay, what is happening here? I'm not feeling comfortable. That in your presence, I don't know why I feel very angry. That I don't feel so angry outside the therapy room, but I feel very angry here. Now, what will the therapist do? One, he can make a narcissistic interpretation saying, I am offering you a safe space. I am such a good therapist. Look, the anger is coming up. But then despite the patient feeling the anger over and over again, you don't see relief in symptoms because you are using him as a system to process your anger. There is an endless flow just coming from you into him. So catharsis keeps happening and the relief does not come.
So suppose, so this is the case where I have unresolved anger in me and I'm projecting it onto the client, right? But suppose I have a positive worldview which can help the client.
It helps.
Wouldn't that projective identification be a positive thing to do, a good thing to do?
Of course, it's a very good thing to do. And that is what
Right.
often differentiates therapists.
Okay.
There have been many studies to find out which school of therapy performs better than the other. And this has been repeated over and over again. And there is no consensus on it. But one consensus is it is the therapist who matters more than the school.
Right.
That has consistently been found in all the studies. And when we say the therapist is more important than the school, what is the therapist doing that is more important than the school? So therapist is doing containment, the therapist is doing interpretation, the therapist is doing projective identification unknowingly. So all of this make one therapist better than the other. So the difference between the therapies is of knowledge, of skills, of so many things, but specialization. But one of the differences is of containment and projective identification. That if you are very positive, people will feel positive in your presence. If you are really accepting, people will not feel threatened in your presence. They will feel safe. So that also is true, that there is a positive version of everything that we see.
Okay. Thank you, sir.
But still, isn't it still subjective? Being if the therapist has a positive world view, he might project and let the sufferings, he might diminish or dismissal the pains and sufferings at times, because the projective identification is at play. It is
Right.
not coming from the sorted wisdom viewpoint. It is coming from projective identity, from need to see the world only in positive way. So that is very subjective.
So that will take us to the positivity with depth and technique, and positivity without depth and technique. Without depth and technique, the person will start speaking from day one all the positive things in the world, and he will become more like a motivational speaker and not a therapist. But when you start with the seriousness and empathy, and you know that this cannot go by positive pep talk, this is far deeper. So first you are operating there, and when the person makes very negative statement, only then you make a positive statement.
So
And
I was thinking when I said positive, sir, I was thinking typically in terms of say somebody who has paranoid kind of PD or slight neurotic suspicion. If you yourself as a therapist may be having a faith in humankind, then you can communicate that through the projective
correct,
identification. That's what I was thinking. Yeah.
that happens, and that's very positive.
Yeah. Yeah. Okay.
It's
Yeah.
very positive. One of the worst things to have is a paranoid therapist for a paranoid patient. You cannot have the Ram Balram in the room.
So, but how do we choose to do projective identification? When it occurs, there is a choice whether I can do it or not. You can't do it.
Can't do it. It's unconscious.
It's unconscious, one. Number two, if you are experienced enough, you know it is at play or something has risen. You make a choice whether to put it across or not. But unconsciously, you have come in touch with it. But you cannot do it to someone. It is recommendation and advisory or giving a perspective. It's like CBT. But projective identification is more of unconscious process.
Correct. So that is where the training comes in. That we can't plan that if I have a session 4 to 5, at 4:20 I will make a positive projective identification. Nobody can do that kind of thing. But when we go for supervision and the supervisor tells us that at this stage of the session, you have made a negative projective identification, it seems. You slowly catch it. Or the patient says that, are you feeling tired? And we are not feeling tired, which means we are putting in something in him. And below that is something. Or our friends tell us, कि whenever you say this, I feel X. So those things, our ordinary life, our supervision, our patients, they make us aware of our very strong projective identifications. And if they are negative, then we work on ourselves. That it's because of excess of something that we cannot handle, that we are putting it in the other. So if we can do catharsis and reduce that amount, we don't need to use projective identification as a mechanism, because it's a very early life, primitive, infantile mechanism. It's a pre-linguistic mechanism. So the more we know ourselves, we analyze ourselves, do the catharsis, heal ourselves, the less we will use this. We now come to a very important element, silence. And there are two silences in the room, silence of the therapist and silence of the patient. And what different meanings can these silences have? Should we break for a cup of tea or should we continue?
Yes, please.
Okay. So we meet in 10 minutes
Yes.
to look at the silences.
Same link. Same link.
Same link, same link. States of silence. Two silences we'll look at: silence of the therapist, silence of the patient. What can the silence of the therapist mean? It can signal to the patient that the therapist is accepting what he is saying. It can mean acceptance. It can also mean rejection, that he is not affirmatively joining in, and therefore he is rejecting by omission. And different patients will feel all of this very differently. Somebody who has a rejection problem will immediately catch up that non-affirmative joining in is rejection. So for such patients, we have to be more in an acceptance mode, explicitly speaking, so that they don't feel dismissed and abandoned yet again. Another group of patients can think of that as dismissal. And all of this can actually also be that. And all of this can be perceived by the patient also like this. It may be the case that actually the therapist is dismissing somebody. Or it may be the case that the patient is perceiving so. He's not actually being dismissed. But the silence can be thought of by the patient in that way. Silence can be used by the therapist to create a crisis for healing. Last time we discussed that when the crisis is on, the psyche becomes more malleable and flexible, and deep-seated change becomes more possible. And therefore, we create soft crisis in the therapy session to accelerate healing and deepen our effect. One way to create crisis is by being silent. And obviously, this does not have to be used with people who have a dismissal problem or those who are extremely dependent in the initial part of therapy. For dependent, only after a few sessions go, we can use silence for crisis creation. Also not to be used where people have suffered from cold or refrigerator mother or refrigerator father. Silence can also be used for containment. That a group of patients who does not want advice, does not want intervention, they want silence. They want a self-object. So there we practice containment by not making an interpretation and by offering silence because the patient wants silence. Silence can also mean encouragement. That the patient is saying something, and by not criticizing it, you are accepting it. It can also be controversy avoidance, that you don't want to get into an ideological dispute with the patient. Because our capability is limited to the psychological area. For example, somebody comes from defense and says, should we go for Rafale fighter or should we go for F-15 from Americans? Now, we don't know which side he is on. And we don't want to unnecessarily create a dispute. So we may keep silence to avoid a controversy. Similarly, you have a patient who is extremely feminist, who is woke. You are not subscribing to his ideology, but you would prefer to keep silence. Because he may not like, and it is not in interest of anybody to create ideological debate in the therapy room. So it may be controversy avoidance. It may be facilitating safety. That when you keep silence and you only give out very encouraging or supporting remarks occasionally, it facilitates the feeling of safety and peace. You may be facilitating internalization of silence and peace. The therapy room provides a silence and peace, and that internalization is very necessary for those who are suffering from anxiety, turbulence, disintegration. They need to internalize the peace and the silence of the therapy room, which is very, very important part of therapy. Internalizing the silence and peace of the therapy room. If the therapist makes too many interventions, that is disturbed. So not to make too many interventions in one session. It may just be because of ignorance, that the patient is saying something and the therapist does not know what to make out of it. Silence can just mean ignorance, the limitation of knowledge of the therapist. So all of this can be meanings of the silence of the therapist, either literally or taken to be so by the patient. Now, patient silence. Patient silence can mean anger. He is silent because if he speaks, anger will come out and he does not want it to happen. So it can be repression of anger can lead to silence, just as it happens in depression. A person is full of anger, does not speak to anybody. It can be because of sadness. He is too sad, too low in energy to speak. In anger, it will be repression, heavy repression. In sadness, it will be low energy generation. The patient may feel hopeless and futile. It's futile to talk to anybody, including the therapist. It may be a silence of hopelessness. It may be resignation of not being understood. Maybe he has had other therapists before and nobody understood him and therefore he has resigned or about to resign. There may be a disbelief in therapy if he is not getting results. There may be very high anxiety, like somebody I knew was in training analysis and very narcissistic person. After some sessions, the therapist complained it's not going anywhere. Because one, transferences were not happening according to him. And two, the lady was using the session time, or rather misusing the session time, so that somehow it gets over. As though she had no interest in getting analyzed, but was doing it only because it was academic necessity. So she would go, she would lie down on the couch, and then she would not say anything, or she would start singing some Bollywood song. This went on for quite some time, almost 2 months. And then she talked to me, we were talking together. She said, this is what is happening. So I said, why don't you talk? And what is the point of spending so much money, energy and everything? Why don't you talk? And she said, the moment I start talking about anything which is on the side of believing in God, believing in holistic healing or pranic healing, he just dismisses it. And I don't like it. Because belief in those things was the only thread she was hanging by. And she can't let it go. There was so much of disintegration inside, so much of fragility inside, that she was holding on only with that. In our talking, when I said it's perfectly okay, that psychoanalysis does not have an answer on these aspects, whether to believe or not to believe. So after our talk, she felt well, good, and thereafter she was able to continue with the therapy. Not like everybody else, the fragility was still there, but she was able to complete the requirements. So anxiety, that if I say something, it will be attacked with an interpretation, that some fault will be found in me, that can also lead to silence. That if I speak, a fault will be found in me and an attack will come. It can just be rest. This happened to me many times because my sessions used to be at 7:10 in the evening after my job. And often I was just so tired that I would just lie down and I was half asleep. So this is like a person is really tired and you are calling him late in the evening after his job. And often he may actually fall into a state of rest, or he is very anxious and it's only in the safety of the room that he actually can go to rest and therefore takes rest. That can also lead to silence. The silence of rest. So all these are different silences.
But silence of rest can also be the rest of the psyche. At times, it is the peaceful presence of that, the space itself, the container itself, which sometimes put a pause onto the patient's psyche, where they use the silence just to experience no judgment, nothing, no explanation, nothing. So it is
Correct.
the rest of the psyche also. It's a pause for a psyche.
Correct. Correct. That is the need for an experience which the person wants. And therefore somebody can go for a session where largely he is silent. Because even in silence, some healing is happening, some requirement is fulfilled. And therefore we say that there is a verbal part of therapy which operates in language, and there is a non-verbal part of therapy which operates in silence. And in silence, what happens is transference, counter-transference, projective identification, containment, internalization of the therapist, internalization of peace, internalization of safety. Those things operate in silence, outside of language. Silence can be for safety, that he wants to feel safe, because everywhere people are attacking him, giving him advices, not allowing him to be himself. And here he wants to be himself. It can be for internalization of the therapist as a good, reliable, stable object, or internalization of the silence, peace, and the safety of the environment. In my own analysis, twice I experienced silent sessions when I was silent for all the 45 minutes, 50 minutes. I went, lied down on the couch, came back, never said a word. And then when I look back, I never felt it was a waste of time and money. Something was gained, difficult to articulate, but something was gained, because often after the therapy was over, I look back. Now let us look at resistance. Resistance comes in all colors and flavors. There's a complete rainbow of resistance. What is resistance? It is an obstacle to the flow of material from the unconscious to the conscious. Entities involved may be thoughts, may be affect. What is necessary for healing, when that is impeded in some way, we call it resistance. So a lot of time goes in therapy in addressing resistances, because only when the resistance weakens, the unconscious can become conscious, and the pent-up affect can be released in catharsis, and healing can happen. So the first resistance is the sheer unpleasantness of the negative affect which is bottled up. That if somebody has anger bottled up or sadness bottled up, the sheer unpleasantness of that coming up is the first resistance. That we are creatures of pleasure. We don't want that unpleasant thing to experience. Second resistance can be reality, fantasy, confusion. Meaning, I ask the patient, how do you feel anger towards your father right now? And how would you like to take revenge? I want you to experience that anger right now in your body and see what visuals come to your mind, how you would like to take revenge and punish your father. And the patient has this unconscious difficulty that if I hurt my father in fantasy, will it happen in reality? Now, obviously, the conscious mind knows it's not going to happen. But in the unconscious mind, there can still be this confusion, and this can be one of the resistances, the reality, fantasy, confusion. That if I hurt somebody in the therapy room, what if in reality they are hurt? So this is what we call the child's magical thinking. But that may still be on in the unconscious. This third resistance can be the omnipotence of the culprit. That I have anger towards my boyfriend, but I have projected omnipotence on him. If I express my anger in the therapy room, what if he abandons me? As though he is omnipotent and he is going to come to know what's happening in the therapy room. So physically he is not there, but psychologically he is there. And this often happens when patients have a fused relationship with the parents. That they feel the parents are psychologically present around them, even though physically they are not. What we call the internalization of the harsh parental figures. That when they do something which the parent would have scolded them for, they have an internal voice which scolds them from inside. Or an anxiety, the scolding will now come. as though the parents are omnipotent and they will be there. So omnipotence of the culprit can lead to a fear of loss or a fear of attack, that if I take revenge, he will attack me even more. So that may inhibit the expression of feelings. Resistance can be guilt. Many patients, after they express anger towards somebody in therapy, after the session is over, they feel an attack of guilt. They feel very bad after the session. So the post-session blues, so to say, when you experience those post-session difficulty, that is attack of guilt, that can be a resistance. That actually is a resistance to the flow of anger. Fear of vacuum. Some people maintain a relationship of hatred and anger because they fear vacuum more than the cost of maintaining a relationship like this. So they are paying a good cost of this relationship, very heavy cost, but they can't let go because vacuum is more terrifying. So if somebody has done something wrong to them, they will not release anger and be done with that person. They will keep the anger inside bottled up and thereby maintain a relationship of hatred and anger. Because if they release all the anger, they will be done with that person and they will have to move into a new relationship, temporarily facing a vacuum, and that object loss is terrifying. There can be a resistance of capacity, that one does not have the capacity to process so much of affect. It's a genuine resistance created by the system. And the way it comes up is when you ask the person to feel difficult feelings, anxiety rises beyond the optimal limit. And the anxiety goes into the smooth muscles or cerebroperceptual apparatus. So either the patients feel nauseating, they feel loss of strength in the limbs, they can feel blurred vision, they can feel stiffness in the head, they can feel the split comes up, they can project a lot of things onto you or somebody else. So this is where the capacity problem comes, that the person genuinely does not have the capacity to process so much of affect. So you have to go slowly, but till that, capacity is a resistance. Ambivalence. You have love and anger for the same person, and that ambivalence creates resistance. It's suffocating. It's suffocating to feel anger in such a situation. Affect can be used as a resistance, very important. Normally we say resistance is towards expression of affect, but occasionally affect itself can be used as a resistance. Meaning, take for example, repeated weeping spells in depression. The person weeps again and again and again. It looks as though so much affect is flowing out, healing will soon happen, but nothing happens. Because the repeated weeping spells are actually a resistance to cover up the underlying anger. So affect itself can be used as a resistance. That one affect covers up another affect. And the real difficult affect is covered up by a less difficult affect. And this is released, but this remains as it is. So in weeping spells of depression, the anger is covered up by weeping. So affect can be used as a resistance. Similarly, anxiety can be used to cover up anger, or anxiety can be used to cover up sadness or guilt. That we believe the problem is anxiety, but actually it's signal anxiety. It's actually covering up guilt or sadness, which is the real problem. Free association can be used as a resistance. which is contrary to classical psychoanalysis. This is what ISTDP believes, and to some extent Lacan also believed in this, that free association can also be used as a resistance, and therefore the variable length method, variable session method. In ISTDP, they use direction. The therapist gives direction to the session to avoid use of free association as a resistance. Dream analysis can also be used as resistance. If a patient knows you are fond of dream analysis and they don't want something to come up, they will keep offering you dreams after dreams, so that the real center never comes. For example, I saw somebody who had come for sociopathic behavior and addiction. He would keep offering something eventful after the other, so that you keep entangled yourself with that eventful things and don't go to the center of his personality. So this can be used as resistance. That can be resistance of projection of will. Tell me what to do. There's a resistance of projection of will. You tell me what to do. So all these are resistances. And all resistances will involve all the classical defenses that we have learned. Repression, projective identification, inversion, sublimation, reaction formation, displacement, rationalization, intellectualization, everything. Any question on this? Yes.
The moment to reduce the length of therapy in terms of number of sessions or coming face to face was also to make it affordable. And then how do we couple it with free association as a resistance?
These are actually two different areas which come together in a complicated way. Reducing the length of therapy has always been a concern for everybody, because everybody feels it's too costly, too long. What has happened is people have tried a lot of interventions. For example, there came something called time limited dynamic therapy, TLDP, TLDT. CBT came up with a 12 session format, that we take up a problem and we don't digress, just be on the problem for 12 sessions. ISTDP came up with the whole idea of directing the person and not allowing free association. But what is coming up is that beyond a point you cannot compress the length of therapy, because there is something inside in our system which needs time to heal, especially in difficult cases. So, for example, ISTDP completely came up with this objective. Its name is intensive short-term dynamic psychotherapy. So it was meant to be essentially a short-term therapy. But what it has found is all cases can be put into three categories: mild, moderate, and severe. And mild can be healed according to them using 5 sessions. Moderate is 15 to 20, 15 to 50, and severe can go to 50 to 150. Now 150, if you look into it, practically you're talking about 2 years. And they have also discovered that in fragile patients, you cannot accelerate beyond a point, because till they build up the capacity, you cannot put very hard interventions in or expect catharsis to happen. So this capacity question puts a natural limit to how much we can compress. And that capacity question till today is almost school neutral, because no school has a recipe how to address this capacity question quickly. So the ideal always is to compress it as much as possible, but the capacity question holds us back. Number one. Number two, free association is not necessarily always a resistance. So it is not synonymous with short-term therapy that you cannot have free association. My experience has been that if your knowledge is deep enough and you can craft some good statements for intervention, even with free association, you can get very good results very quickly. So the free association is not necessarily an enemy, although occasionally it can be. And when it happens, we cut it by intervention. But in some situations, for example, somebody comes in a manic state, you will need quite some time before he cools down and comes down to ordinary therapy state. Or somebody is coming back to you after a long time and there's a lot of things to share. So unless the person empties out the surface, how do you go to his depth? And emptying out the surface will need time and free association to allow him to speak whatever he wants to speak. So what I do is, in such situations of mania or coming back after a long time, I allow the free association to happen, emptying out to happen. But in regular therapy, if I see that as resistance, then I intervene. And I have not found to be an unsurmountable problem so as to dismiss it wholesale from the therapy approach. I still see a lot of value in free association, because often the person starts somewhere and then goes exactly to the heart of the problem.
Thank you, sir.
Now, doing the therapy, how do you start the session? The first is starting the session. This is different for different people and different at different stages of the therapy. Somebody comes to you, first session, you will have to do more talking. You may have to start the session. The same person comes for 25th session, you just keep quiet even if he is quiet for 10 minutes. If he is a dependent person, you may like to start occasionally. But if he is not dependent person, you can allow him to take his time. So till the bond builds up, you will have to do more talking and you may have to start the session initially. Ideal is the patient's unconscious starts the session. So starting the session is a very important point. One of my teachers used to say, what is the objective of the first session? And he would say, it is to seduce the patient for the second session. And then he would ask, what is the objective of the second session? Seduce the patient for the third session. Because if he does not come for therapy, no tool can be applied. The first requirement is he should continue in therapy. So anything that facilitates this is fine. It's good. It's very utilitarian. What works is good. So starting the session, if the patient is coming new, first 3 or 4 times you may start the session. If he is dependent, you may start the session. If he is using silence as a resistance, he is unable to overcome his own resistance, you can start the session. But otherwise, as a rule, allow the patient to start the session. Allow his unconscious to start. How much to speak is also dependent on the type of patient. Early in therapy, you speak more. As the therapy progresses, you speak less and less. some people who culturally are not used to silences may find it very awkward. So for them, you will have to continue to speak more for a longer period of time. Third, how long do you wait for free association to converge? There are two parts to it. One, situation one, free association is made and you are supposed to do the unconscious interpretation. And in that unconscious interpretation, the convergence already is there. The patient does not have to literally converge. He is implicitly converging. And it is up to you to make that interpretation by using your knowledge. That the patient has talked of three different things, but all the three are related to object loss. Patient gives you three stories. Yesterday, somebody living next to me, somebody took away his bike, stole away his bike. And then after some time he says, at times I remember my school, how we used to play. Now both of them are connected by object loss. The loss of the bicycle, the loss of the school. So apparently it is free association. But if you apply psychoanalytic theory, it's already converging onto something important. So there may not be divergence at a deeper level as you see at the literal level. But if you don't find anything, then you can intervene. But till then you allow it to go on. And most of the times I have seen it converges to something very important. Third important point in doing therapy is the unconscious story unfolds session by session. So at times there is a divergence and coming back. At times it's like a TV serial. Episode by episode it unfolds. And we have to connect it. Then what is happening in the last 3 episodes? And that brings in a very important point. Should we bring in a mention of the last session, or should we look at every session as an independent session? In classical psychoanalysis, we always see this in totality. In ISTDP, we see every session independently as a new session. So in ISTDP, we never bring up, you said so last session. We don't make a reference in our communication to the last session. But in classical psychoanalysis, we do. Often we can make a remark which involves what is said in the last session. Something is said in transference. It is very important to find out. Said silently. And this is also always true of deep-seated traumatic things. There is a poetic line by Larkin. It's a very good line. Always like it. He says, trees are coming into leaves as if something almost said. So the powerlessness of language to say everything, that does not mean it cannot say anything. Neither of the extremes are true. But that trees are coming into leaves as if something almost said. So that kind of thing in very deep-seated issues may happen, that the most important things may get said without using words. Like I said, the counter-transference part. In some case, it will be in between. The person gives you imagery, either a dream or something he says in the session. What do you do when the patient tells you how to do therapy.
In a way, he's telling how to deal with him.
So there are two parts. If he is narcissistic and explicitly says it, right, you have to just keep it in mind what is at play and you keep doing your work. But if it is conveyed implicitly, then it is very important communication. Last time I gave an example of that visual, the mashal wala visual. 28 people standing in a line with the mashal, the flame, and lighting it up one by one. That was a very powerful visual where the person is telling me how to do therapy indirectly. He is telling me to focus on object loss, on the persecutory anxieties, on being the wise man who can save him from persecution, and of the fact that every day till 28 years of age, this was what he felt, the persecutory anxiety. So when a person communicates a dream or a person communicates a visual, a very vivid visual, or the person tells indirectly about something about somebody, the person is indirectly telling you how to do therapy. That has to be gladly accepted. It is the unconscious telling us how to heal it. Straight from the horse's mouth, how to heal the horse. Patient announces withdrawal from therapy. What to do? Very tricky thing.
Give him the interpretation. I do that sometimes. And they show up after 3-4 weeks, then again.
The summary of what has been covered, ask what are his plans for the future and wish him all the best.
Correct. Correct. Some cases, sorry, please go on.
For the patients who have been totally into the Freudian frame with me, I give them the interpretation.
Right.
Long-term patients, I do give them and I tell them that you have chosen this, but yet this remains whenever you feel up for it. And yes, after a year or 2 year also, they do come with
True.
preparedness to come for it.
This will be, when it happens is very important. Situation 1, a lot of symptoms have been healed. What has not been healed has been thoroughly understood and accepted, and the person withdraws. We wish him best of luck. We understand we have a, it's called closure. So we have a last few sessions for closure. Any good termination process will have dedicated sessions for closure. So we make a request that it's fine, you have decided, I respect your choice, but can we have 2 closing sessions? And in the closing sessions, we review everything that has happened. Partly it is a walk down the memory lane. It's nostalgic. And it's also integrating and consolidating. And we don't have an abrupt withdrawal. So this is one. Situation 2, the patient is in anger, won't listen to anything. He just says, I don't want to come. We maintain our calm and we tell him, perfectly fine, as you wish. I wish you had come for a few more sessions. We could have accomplished a lot of things. But it's always open whenever you feel like you're most welcome. Situation 3, the patient tells you in a roundabout way, and patient is knowledgeable himself. So let me give an example. I was seeing a psychiatrist, and the psychiatrist said after a few sessions, what we have done, I want to put it into practice and not get into a situation of knowing too much and operating too little. So let me put it into practice and get back to you. So I said, perfectly fine. How much time would you require to put it into practice? He said, 2 months, fine. After 2 months, I wrote back to the person and I said, have you been able to put it into practice? If yes, everything is fine. If no, then let us look at the resistances. This is what I did. Person has still not come back because there is too much fear of the feelings. And
Much
there's
fear,
also, sorry,
too much fear of the
feelings coming up from inside.
feel.
Everything is so much bottled up. There's such high amount of bottling up. And the second is the closeness to the therapist. So there are two fears. One, fear of upward movement of feeling within oneself, and then from oneself to the other, that L shape. The first movement of the feeling is inside, bottom to the top, unconscious to the conscious, and then towards somebody. And both these paths are difficult. Resistance is on both these paths. Some people have resistance of internal movement of feeling. Some people have a resistance of the external movement of feeling. Some people have it both. Most patients, before they leave therapy, they will tell you in advance indirectly. What do you do in a stallmate? Nothing is moving.
But isn't it the best goal achievement of therapies when the patient announces that they'll be closing it soon because they have internalized the whole system?
Correct.
That's the ideal announcement of the
You can
therapeutic
also
session.
look at Wilfred Bion, and there was a very famous physicist, quantum mechanics physicist, Pauli or somebody, I don't know who it is. There are two famous quantum mechanics physicists. One went to Carl Jung and one went to Wilfred Bion. I'm forgetting the names. But in Bion's biography, they write that after almost year or 2 years of therapy, neither of them was satisfied. Neither the therapist nor the patient was satisfied that adequate thing has been done. And both of them agreed, okay, this is the best we can do. So they closed the therapy. And Wilfred Bion, after the last session, went with the patient on a dinner, which is like a blasphemy in psychoanalysis. That is how they closed it. Okay, the frame is over. Now we can be just two individuals in society.
But the frame is never over. We
Yeah,
all know that.
correct.
Because sometimes the voice, just the way the different voices have existed in their mind, the therapist voice remains, if internalized, as their own wisdom or the therapist voice itself. So it is something to be internalized and it is eternal.
Correct. So I always say that some stories can never be told. Some stories are so deep inside they can never be told. In fact, there is one of my lectures on the YouTube is this: some stories can never be told. So it may happen that even after extensive analysis, both of them decide to stop, but obviously some stories remain untold. The stallmate. What to do with the stallmate? Nothing is moving. Try all the tricks you know. First, try the supervisor. Does not work, try a consultant supervisor who is specializing in an area. If nothing works, don't bring in your narcissism, let it go. Talk to the patient and ensure a smooth transfer. Transfer of the patient from one therapist to another is an extremely difficult process. Very delicately to be handled. Always to be done only with consensus. We cannot give the patient experience of a second abandonment. At the same time, we should not be blind in our narcissism that we keep trying year after year and nothing happens. Some people take pride in this fact, this person was me for 7 years, 8 years. Now, we have to be careful about our narcissism and the real necessity. So if we are not able to do something, we should be honest to accept that in this situation, I'm not able to do anything. Sparks flow. If there are no sparks in therapy, it is not therapy. Then it's social occasion. You are playing it too safe, he is playing it too safe. Nobody is honest. It's a platitudinous discourse. And we do not want a platitudinous discourse. So at some time, sparks will flow. It is our therapeutic alliance which has to be stronger than the sparks so that it goes on. Especially when negative transparencies happen. When negative transparencies happen, it is only our capital of therapeutic alliance that saves us. Apart from our containing capacity at not responding to negative transparencies with negative outbursts. Unbearable states of mind. This always happens. A few years back, there was a conference in Delhi with this title. Unbearable states of mind between the therapist and the patient. And they had invited all the research papers on the unbearable states of mind, which both of them experience in the therapy room. Yes, please.
For me and my patient, it is with compulsive patients, not with OCD, but OCPD people. When they're compulsively bringing the same thing, that is where I need to work.
Right.
There is a lot of irritation in me at that time.
The stubbornness and the obstinacy of the OCPD or the OCD.
OCD is still accepted by my mechanism, but OCPD I just cannot. After 10-15 sessions, I have this irritation. I have felt that very clearly in me that I get irritated.
You will also feel that in schizoid.
Oh,
Schizoid personality disorder.
schizoid and schizotypal, both odd and eccentrics.
So we have to discuss it with the therapist or our peers or spend considerable time doing self-supervision for getting us out of these remnants of unbearable states of mind. The patient tests you. This is a very important part of therapy. They will test you by seduction. Do you fall for it? They will test you by projective identification of anger, by projective identification of anxiety, by being difficult and see whether you abandon or not abandon.
Arresting the interpretations.
Correct. Only when the patient tests you, and we are talking of all difficult cases, of course, they will allow the real whole thing to come. If you're dealing with something which is involving Oedipus or incest or homosexuality, they will even test you first for secrecy. Whether you can maintain confidentiality or not. And only after a long time they will let it out.
With paranoids also, it is very difficult.
Correct. Correct. Should we go on or should we do it next time? One slide. Okay, we can do it next time. Okay. Thank you so much.
Thank you so much. Thank you.